Welcome in Nijmegen. Most of you, I see some familiar faces, so kind of familiar here in Nijmegen and at the Han University. To start to begin with, and David didn't know, but actually you all think that you're now in a lecturing hall, in a theater, isn't it? But actually this is a kind of a holodeck. This holodeck transformed in a theater. So sometimes you see some glitches at the side rays. It's kind of just an illusion, like some more things are illusion. You didn't know, isn't it? You didn't see it.
No.
No, it's quite strange, isn't it? That people don't even see. We're on a holodeck. It's the first holodeck in the world, and they built it here in Nijmegen. They saw it kind of in Star Wars or Star Trek. That was the first one. They had the holodeck, and this was the thing that they thought, well, let's build it in here. So sometimes you might see that it changes shape in it, but then don't be alarmed. It's just natural. But so I thought it would be nice to start with that one, that people know what to expect.
The first of many surprises.
Yeah, surprises, because that was kind of the idea, to have surprises in here. Yes. Welcome. We do a slight introduction. What's the plan? I'm really glad that everybody's here. Just some tiny little notes. Some of you came with the car. The parking places are open. Although if you are below the first level, -1, then it might go closing at 10:15. So afterwards we might have a drink. Then you think, please take your car out before 10:15, because then it's closed and then you can wait until tomorrow morning. It's a little bit of a long time, so that would be quite important to know already. So, the end of physiotherapy towards new ways of health. So we're going to be a little bit. We try to bring you in this evening to take on a journey of thinking. What are the assumptions? What kind of questions do we ask? What do we think about physiotherapy, about health, about the world? We invited Dave to help us, to guide us, to ask also the questions. Maybe we even got answers, but we don't know. But to give answers, we have to know the questions first. That's the hardest part. So, not further ado, I just got a little bit of introduction, I guess, towards us, and then we start going. And then kind of an idea, what's the expectations of you? Is this, before we start, are there any expectations already that think, oh, we really hope to have an answer on those kind of questions? You're really open in this one. So just.
I want to have a date when it ends.
You want to have a date when it ends?
My boss at my home university keeps calling the book The Death of Physiotherapy. I keep telling him it's not the death.
Yeah, that's a different thing. It's in the end of the death.
It is very much a different
also
thing.
A different connection there. So there's not really expectations yet, at least not obvious. So we will discover them more afterwards. Also, what the thing that we hope to do. We hope actually only that we share our thoughts, and also to share and embrace diversity and differences, and that we don't only go for the thing that connects us, but also try to figure out what disconnects us. What are we different in? To find a little bit chaos into the world, so that we have the different objectives and see what's out there. So we get curiosity there, and to see what direction we can take. First, a tiny bit of introduction about me, and then afterwards get David. So this is quite tiny. Well, my name is also my hometown. My name is Van Wijchen. This is actually the castle that we live in. No, of course. No. But this is the castle of Wijchen, my hometown. I'm a physiotherapist. I'm graduated here in Nijmegen at Hogeschool Nijmegen a long time ago. I started as a physiotherapist in Norway, so I feel more a Norwegian physiotherapist than a Dutch, because that's where I did my first paces as physiotherapist. And afterwards I graduated in England in Eastbourne at the University of Brighton. In between I did Sant University concerning manual therapy, and at the moment I'm involved in some kind of things like bandy. It's a kind of ice hockey, field hockey on ice, not ice hockey. That's the kind of thing as a physiotherapist. Refugees project together with different universities, and especially experiments in physiotherapy education. And a little bit in kind of I got introduced into critical thinking in the critical physiotherapy network, and that's also the way why I met Dave. Dave.
Hello. Good evening. How are you all? First of all, a huge thank you for inviting me here. It's a long way from New Zealand, as you probably know, about 26-hour flight. But it's a real pleasure to be here and to have this evening with you as well. I've been in the Netherlands for about less than a day, and I've discovered two things already. First, this, which I've never seen before. This is quite... do you all know that this is? Oh, this is incredible. I mean, this is just we don't have much technology in New Zealand. We've only just developed electricity and cars and things, and this is quite remarkable. And then the other thing that I've discovered is this. How have I lived my life without this before? This is truly beautiful. So yes, thank you for the invitation to be here. I've talked about the book and a lot of the ideas around the end of physiotherapy in lots of places. I have to say I've never talked at a place with a balcony. This is quite something, this is. I thought I'd show you a couple of pictures to sort of ground you in where I'm from, just a bit of background. As you can probably tell from my accent, I'm originally from England. I lived for 30 odd years in the English Midlands here. I'm from just a town just north of Wolverhampton. Those of you who are football supporters will probably know that Wolverhampton Wanderers is the best football team in the world. Here they are, actually. My hometown is relevant to this because I was born in a small, tiny little village called Armitage. And Armitage Shanks produces toilets. So I can go all around the world and go to a toilet and think of home. And so that's why the picture's there. This is where I trained as a physio at New Cross in Wolverhampton. And this is my sort of family roots. My family all comes from very old coal mining families, very poor areas of the English Midlands. And then this reference here is to some of the work that I've done since becoming a physio. I was very drawn to social sciences and philosophy, and have done a lot of work alongside physiotherapy to try and think philosophically about healthcare and where things like health professionals go, where they come from, what they do. And this person here, some of you might know, Michel Foucault, is my hero. If you've ever seen a picture of him, we look remarkably alike. I can promise you I haven't tried to shape my face to look like him just by accident. That's my family, up in the top corner there. This is my front garden at home. This is in the middle of winter. New Zealand's very fortunate having a very temperate climate. My home university, AUT, Auckland University of Technology. There are only 2 physio schools in New Zealand, but AUT is massive, has a big intake. We took in 260 students in our first year this year. Really big programme. And some of you might know that I was involved in setting up the Critical Physio Network, which originally was meant to be just a small group of people who were thinking differently and critically about physio. It's now just gone crazy in size. It's got more than 650 members in more than 40 countries. And in the last few years, I also helped set up the history group, which is trying to preserve physio history and think about the way that we practice. This is not far from my home, this beach up here. New Zealand's a very beautiful place. Those of you who've been there will know. It feels a lot like, I've only been in the Netherlands for about a day, but just wandering around Nijmegen today, the feel is very much like Auckland to me. The way that people are, they're kind of... New Zealanders are quite gentle people, quite sort of calm and relaxed. We have a big country next to us, which is very big and brash. And New Zealanders aren't quite like that. We're more like this and this. We're more like this and that, really, as people. And this, of course, is the most interesting picture of all. This is a picture of traction, obviously done, because my passion as well as philosophy and thinking about physiotherapy is to try and trace its history, to try and understand how we came to where we are today. For me, the purpose of history is to try and understand the present and the future, to try and diagnose where physiotherapy is and where it might be going. So, shall we press on?
Yeah, shall we press on? I think so.
Okay, so yeah, thank you. So The End of Physiotherapy, which is the book that some of you might know, some of you might even have read, I don't know, is the first of 3 books that are essentially a series of books trying to diagnose physiotherapy. This is the second one, which will be finished by the end of this year, early next year, and I love that title. I've kept that title just like that because I like how the words work. I'm very simple like that. This book, this book is essentially a work of critical history. In other words, trying to trace the historical roots of the present, the historical reasons why physiotherapy is facing the problems it's facing now. I think the problems that you're facing are very similar to the problems that we're facing in New Zealand, that are prevalent all around the world. Encroachment from other professions, the deprofessionalisation of the profession, the reducing public funding for physiotherapy, and people's antagonism towards orthodox professions and their appetite to try lots of new things, the availability of lots of competitors, the difficulty in proving that what we do works. These are problems that we're facing now on quite an unprecedented level. And what's significant is we are not really coming up with the answers. We don't know how to answer those problems, and that's the problem that this book attempts to deal with, and I'll come on to explain a little bit more about it shortly. This book is essentially a work of sociology, so applying a social view, a sociological critique to physiotherapy. So this is historical, that's sociological, and this is then going to take a philosophical view, and that will be written probably in a couple of years' time. So I thought we would start by talking a little bit about the idea in the book and something about what the book tries to do.
Yeah, in the meantime, who of you have read the book?
Oh no, I'm not looking.
No, please. So I will just try to figure. Somebody has read some bits. Okay,
Good.
So, are you a little bit interested to hear a little bit more about the book from Dave's view? Would that be helpful for those of you who have not yet read the book? So,
I know this for a fact, but compared with medicine, nursing, occupational therapy, psychology, a lot of other health disciplines, we have no history in writing critically about our profession. We have hundreds and hundreds of books about clinical techniques, methods of assessment, really important and impressive books. But if you look at, say, the medical profession, there is a long history of people looking at medicine itself and saying, what is it trying to do? What's its focus? Where is it going? And actually sometimes in quite critical ways, trying to change the profession by saying these things aren't good. We have no history of doing that. And so this book is, I think, perhaps one of the first books that's ever tried to do that. So the question that it asks is this: how did we arrive at this point in our history, facing these problems and these issues? And then from that, what is the future for the profession? So the book is divided simply into three sections. The first part, the orange blocks up here, deals with a series of historical events. The period before physiotherapy formed as a profession, the events that led to its formation, and then important social points in the history of the profession. So the period preceding World War I, the period immediately after World War I and the birth of the rehabilitation movement and the development of welfarism, welfare state ideas, public health services, and then the neoliberal period from 1974 onwards. And they are taken as those points in time for quite specific reasons, because the fundamental argument in the book is that the reasons we're facing the issues we're facing now in the profession are economic and social and political. And so those points in time reflect certain significant points. So for instance, if I can give you one simple example, physiotherapy grew massively after the First World War, not because we proved a new technique or not because we developed a new strategy. It's because the government said, we feel ashamed of the fact we've sent these young men to the war and we've caused so much illness and injury. We need to compensate society for it by creating a service that rehabilitates them. And because we'd proven our legitimacy in the years before and our allegiance to the medical profession, it was physios that got that job. So our growth as a profession had nothing to do with evidence, had nothing to do with clinical practice directly. It was a political event that led to that change. And after 1974, it's a series of political events that have led to the problems we're now facing. So that's why the book takes those periods in time and tries to understand what those political events were. The middle section of the book takes 4 broad concepts that are important to physiotherapy and critiques them and unpicks them. The body, posture and movement, function and rehabilitation, and embodiment. 4 chapters dealing with 4 key aspects of physiotherapy, and then basically pulls them apart, critiques them and says why we take certain approaches to those things. And then the final section of the book is really the application of that to education, practice, research, and the regulation of the profession, the disciplining of the profession. So, what are the answers that the book comes up with? Well, the answers that we derived as a profession were, first of all, we proved that you could teach people to touch legitimately. In other words, you could get past the prostitutes and the people who had only practiced and trained for 20 minutes. We proved that there was a way to touch people legitimately that the state and the medical profession was happy with. So that gave us our sponsors, that gave us our patrons, the people who would carry us forward and give us funding and legislative protection and such.
Maybe just an interruption, Dave, because you say it's the legitimate way of touch.
Yeah.
And then you make this distinction between physiotherapy and almost and prostitutes there.
Yes, yeah.
Can you elaborate a little bit?
So,
because at least that makes sense that we understand why you make that connect for those. Yeah.
So the book focuses a lot on the period when I argue physiotherapy was born internationally as a profession. And I don't agree with Anders Ottosson that it began with the Swedes in the 19th century. Because, for one, they weren't called physiotherapists and they weren't a collective group of physiotherapists. And secondly, they were just using modalities that had always been there. Massage, gymnastic movement had been practiced since Greek and Roman times. What made the 1894 birth of the Society of Trained Masseuses important is that they organised into a group and they said we will work together to form a society that will compete against our competition. And in 1894 in Britain, in London particularly, there was a massive problem with massage. Massage could be done by anybody. You didn't need a certificate. You could advertise in the back of any journal or magazine. And if you were looking for a massage, you wouldn't know that the person you were going to was trained for 20 minutes or had had a lifetime of experience or was a prostitute. Because at the time, if you were a prostitute, the way that you got around the law was to say you weren't, you were a masseur. So the nurses and midwives who were trying to form this proper profession, this legitimate profession, had this competition from prostitutes and from people who'd had 20 minutes of training. And they were trying to say, how can we touch people and practice this in a proper professional way? And it's what they did in forming that society that is a key part of the book. So that to show that they were legitimate was critical. And that, I still argue, is a massive issue for us today. And the book goes on to talk about this a lot. For instance, physios have a real problem with massage. We still have a problem with massage. Right now, massage is going through a bit of a decline. People don't want that don't want to do that kinds of hands-on treatment. But there have been times in the profession when it's been really popular. At the moment, it's very difficult for us to do massage on somebody just because it feels nice. Now, I've worked in respiratory care all my life, and particularly with elderly. And I've worked with people, say, in palliative care with end-stage cancer. And sometimes one of the best things I can do for them is just a very gentle effleurage back massage. It has no physiological benefit whatsoever. But for that 40 minutes or so, or however long I'm doing it, I know that that person is transformed away from their pain. For that 40 minutes, they're somewhere else. Because I'm good at my job, I know how to use my hands, I'm careful and caring. Now, when that massage is finished, within 10 seconds, they're back to their old world of pain and suffering and nastiness. I can't justify that massage today based on our physiotherapy rules. Because physiotherapy can't do that work. It has to be evidence-based, there has to be a physiological rationale for it, there has to be a reason for it. The problem with me doing massage just because it feels nice is that it brings back that whole problem of sensuality. Massage is a very sensual thing, or it should be. But sensuality brings back that whole thing about sex and massage related to touch and sex. And that's what the prostitutes do. And that's what we were trying to get rid of 120 years ago. So a big problem today with how massage is being thought of by physios goes back to our long history. I wonder whether we can just jump way ahead here.
Yeah, no, but please go. No, but this is good. I think that it's nice to have a little bit of elaboration in this part, because this is kind of the start also in the talk, and that's why I thought, well, it would be nice to.
Yeah. Okay. Earlier on today, you took me through the department here, the school. I took a couple of photos downstairs. This was one of the photos in the clinic room. Why do you think physio treatment beds look like that? Now, I know that they have to go up and down for ergonomic reasons, and I understand that they're segmented so different parts can be placed. But why do they look like that?
Non-sexual.
They're non-sexual. Imagine if you went to a physio, you're a patient and you went to a physio clinic, and then you'd never seen them before, and you walked, they shook your hand and took you into their clinic room, and you opened the door, and in the middle of their clinic room was a double bed from home. Fluffy pillows and duvets and things. What would you think the physio treatment's going to be like? The reason our beds look like this with all the mechanical parts with them is absolutely about ergonomics, of course. But just as much, it's about saying to the person, this is not a bed from home. This is a legitimate treatment you're going to have here. We're going to show you the machinery so it's not like a bed from home. So there is sex in that bed. The avoidance of talking about the sexuality of what we do is written into everything we try not to say. I was trying to show you another picture that's kind of related to this. Okay. If you go into an image search, Google Images or Bing or something like that, and you put into the search box the words treatment room, these are the images you get. This is just a screenshot that I took a few weeks ago. Now, what sort of feeling do you get about these rooms? Warm? The colour tones are quite warm, aren't they? Yeah? Luxury, pleasant. Yeah. Yeah. Clean. Rich. Yeah. Now, if you put the words physiotherapy treatment room in, this is what you see. What sort of aesthetic are you getting there? Cold, clinical. You used the word earlier on, we were talking about this laboratory.
Yeah, laboratory. So it's away from real life. You really create a laboratory to do something, and then you transfer somebody again to the real life situation.
Now, I don't think this is by accident, but there is something being said by physiotherapists when they design their clinic rooms like this that we don't talk about. I've never seen a paper that's argued why this was, or analysed it, or anybody who's critiqued it. It's just done. It's just custom and practice. Now, I don't think there's anything unpleasant about this. I think this says professionalism and cleanliness, but there's nothing particularly clean about a white wall. White walls aren't any cleaner than green ones. But that's not what it's for. And similarly with these pictures, you'll see these kind of anatomical charts all over the walls in physio clinics. Is that because the physio can't remember where adductor longus is, and they kind of, here's the patient, they're just checking, oh, that's yeah, right there, I'm on the right bit. And then, of course it's not. They're there to convey something to the patient. Everything is there for a reason. Everything in those clinic spaces has been chosen on some level to convey a message to the patient. And it's a very different message to that. By comparison, this speaks about sensuality to me. This speaks about a kind of engagement the person has, which is maybe more holistic and more embodied, maybe more relational, maybe more humanistic, intersubjective. And so by extension, that's less so. That's about detachment, about objectivity, about value neutrality, about measurement, about coldness, about a kind of distance. Now, maybe when we think about the problems being faced by physios, some of it can be found in our clinic rooms. Some of it is there in staring us in our face. And if we go back to the picture I showed you earlier on, let me just jump back. This is in the corner of the treatment room in one of the classrooms. Are we conveying something to our students about how we want you to approach the patient, the client, the customer, whatever phrase you want to use, that conveys more than just this is how you position somebody to do a PA? It's more than that. There's more going on here. And a couple of other pictures from, I love this. This is in the corridor. Now, over the last year or so, I've spent a lot of time doing work around the images in physiotherapy and physio imagery. And these kinds of images, if you forget the bed for the moment and look at the image behind, that's a classic image. You'll see that in so many physio textbooks and so many websites about physio. And if you just forget what its message is at the moment and just ask yourself what you're seeing here, you're seeing a person's arm and a person's leg. Now, why would you use that as a picture to say this is physiotherapy? Well, one of the reasons why you might argue is that what you have here is an anonymous therapist, which is a good idea in a physio school because you want the student to assume that, oh, that could be me one day. You know, I'm going to be that person. You want to be able them to transpose themselves into the shirt of that therapist. But it's also saying what we're interested in here is technique and body parts. There's not really people involved so much in this. This is about technique on a body part. And then when you combine that with the bed that strips away all the subjectivity and sensuality and humanity from it, the students are getting very strong messages here about the kind of way that they're supposed to think about patients. It's not surprising then that we have some problems getting our students to understand about empathy and adaptability and flexibility and caring and compassion and those kind of things, because all the way through, here's another picture from the department. We are fed these images as physios from the very first day of training. This could be any person. This isn't in fact a person. Person could be black or white, they could be young or old, male or female. They actually have no gender. They have no genital parts. They are just a muscle. And what this kind of says to the students, I think, is that rectus muscle is the same as every rectus muscle. One rectus muscle is the same as another. It doesn't really matter what the person's life story is or what they bring into the room. Focus on the muscle. And one of the important points in the book, probably the most important argument in the book, The End of Physiotherapy, is that idea of approaching the body in that way has been absolutely pivotal, crucial to the growth of physiotherapy. That ability to look at the body as a machine is perhaps the single most important feature in physiotherapy, becoming the third biggest profession allied to medicine in the world. 500,000 physiotherapists practicing around the world owe themselves to a very large extent to this ability to look at the body as a machine. Because in the 1890s, this was the way that these founders of the profession realised they could legitimately touch people. These women were trained to not see the inside of a person's thigh or see them as any kind of sensual or sexual way, but to focus on the adductor longus or the hamstring muscles or the biceps femoris or what have you.
So in essence, those masseuses, they disconnected, you say, the person from the body. And by disconnecting it, it helped them to be legitimate as a profession.
Yeah.
So that means also that the personality from the person, the psychic, the social environment, you took it away, isn't it? From that sense? So it wasn't really a person, it was just a body or a body part.
So let's jump back a little. going to give you a break in a second because all this is really heavy. So they proved by doing this, taking this approach, that you could touch people legitimately, but what you had to do is you had to desensualize the person. You had to treat their body like as a machine. And in that way, that worked well with medicine. That's how medicine worked. And it also showed that they could be completely trusted as a profession. So the rules that they set up were really interesting. I don't know whether you know this, but the founders set up a few basic rules in the very early weeks of setting up the society. And those rules are still relevant to how we practice today. One of the first ones was that they were not going to train men or touch men. They were going to be a profession for women, and that existed from 1894 right until the First World War in 1914. So they said, we'll deal with this sexual tension by not having any contact with men. Which is quite funny, really, when you think about it, because if you were a man in Victorian England and you wanted a massage, you had to go to a prostitute, because they wouldn't touch you. But that's how they dealt with it. They said, we will only train and treat women. They said, we will never prescribe drugs, and that they will take referrals only from the doctor. Now, this was a real risk, because at the time there were many, many masseurs practicing. And to limit their market was a real risk, because they might have run out of work. But it was crucial, because the doctors gave them good quality referrals. And they also said that they would put you through an examination. They would test your ability to practice properly, legitimately, and they questioned you in the exam paper on your professionalism. And you had to do the exam to become a member of the Society of Trained Masseuses. There weren't enough of them to do the teaching. They couldn't teach everybody. There was only a handful of them. And people were all over the country wanting to be masseurs. So they couldn't teach them. But what they did was genius. They said, we won't teach you, we'll just examine you. And if you want to come into the society, you have to pass our exam. And because that's what they did, they set the standard of practice through the exam. You couldn't get in unless you passed that exam. So here's a question for you then. Why would you bother going through the Society of Trained Masseuses exam and proving that you met their standard if you could just practice anyway? You could just advertise in the local press and massage people forever. Why would you bother?
Maybe it's nice for this point also that you just have a little chat with the people around you. So about the idea, about the question of Dave, and then we answer afterwards in 2 minutes. So you can also have your mouth muscles working a little bit by talking. Yeah. So just to chat about it, and then we get back to it.
Why would you bother going through the STM's process if it's just easier to go and advertise and start doing it?
Yeah, it's nice.
Okay. Because I'm basically a 5-year-old, I really want to see this working. Can I throw this to somebody so they can talk to me?
We're all trained in catching it.
Yeah? Oh, I'm sorry for the head injuries I caused. Can I throw it to you?
Yeah.
That's just,
Oh.
wow. It typically doesn't work. So this is the first time one works. Yeah, we had a good debate here. We were kind of sure it was money, but then we realized that we're all women, and we thought they might have been less driven by money than men.
Ooh.
But
All right.
yeah. So we also had status, but that maybe the same thing comes up: legitimacy, belonging
Referrals.
to. Yeah, that's money, referral, steady income, and becoming the norm. Those were some of the things that we talked about. Did we win? Or, normally, I can now throw it to
Yes.
someone else.
Throw it to somebody else. Yeah. Oh.
Yeah, it does still work on. We discussed about it too, and we were thinking it might be intrinsic motivation to see you grow up with your peers, to belong to those peers, and to how to say it in English, but sometimes you want to be other than others. You want to
Distinctive.
distinct yourself from your other persons. Yeah.
And that point about distinctiveness is crucial to understanding professions and their professional boundaries, which is to some extent what the second book is going to concentrate a lot on, that distinctiveness thing. Both of you are right so far. I can qualify a little bit maybe, but they're both right. Any other thoughts other than those? Social why social status? What would that? Where would the social status come from?
I think derived from the paramedic. So
Yeah.
they're in the lift with the medics.
Yeah.
So it's with, I have to, yeah.
We need the mic. Can we
Yeah,
throw
so-
the mic over?
So then you get the mic. And it's always not so very clever idea to throw something towards me.
It might have to do with social status, and this status is easily derived from going with the medical society and be a paramedic. I think, and that would be quite distinguished in that time.
Yeah.
And you're not a prostitute anymore.
There's an article you'll find that I wrote in 2006 called Physiotherapy and the Shadow of Prostitution, which is all about this. You know, one of the things as well about all professions, and that's not just health professionals, but all professions, is they have a doppelganger. They have a twin. Medicine, it's the quack. And there's a woman called Valerie Fournier who's written a lot about how medicine doesn't want to get rid of quacks. It wants to keep quacks. Because as long as there is a quack, then a doctor can go, we are better than them. And I think physiotherapy, it's prostitutes. I think our dark side is the fact that we are constantly battling, to some extent, to legitimize our touching, our hands-on work, our practice. And the dark side of that, you know, the sensual, the erotic, the transgressive side of that practice is prostitution. In fact, I did some work with a colleague of mine who's a nurse, Dave Holmes, who's a professor of nursing in Canada, and we wrote about the work of Georges Bataille, who's a French philosopher some of you might know, who's written a lot about transgression. Bataille says that if you want to understand where society sets its boundaries about what it tolerates, the thing you have to do is go way past there. You have to transgress them. And he particularly was interested in European Victorian repressive notions of sexual conduct, about heterosexual being the norm and such. And so a lot of his writings are really eye-wateringly obscene, because he says if you can read that work and understand that you don't like that, then you can work out where you do set the line. And Dave and I wrote this paper called Discipline, Desire and Transgression, which was about physios touching, and saying that we've set our boundaries around what's legitimate, say, here. But if we're going to understand why that might be good or bad, we have to have a method for doing that. And Bataille's argument is you have to transgress it. So you have to break the rules to find out why you've set the rules there and see if you're still happy with that. One of the issues why this is so important for us right now is because we've got an ageing population of people with much more long-term chronic illness. Many more people now are after more holistic experiences of health, more embodied experiences of health, and they have conditions that can't be cured. So they have to live with rather than be cured by. Much of physio's biomechanical approach works well for curing, diagnose, fix, discharge. It doesn't work well when you've got a person with chronic lung disease or chronic arthritis or Parkinson's disease or such. So if we only touch people and manipulate and mobilize people in a way that's based on an acute, self-limiting, fixational kind of fixative model, it won't work now that the whole world of healthcare is moving away. We have no model, no principle for being alongside the patient. Most of our treatment, most of our economy of healthcare is based on a short period of treatment, diagnosis, fix, discharge. Now, that's really where the whole point of this book goes. The reasons why we are like that are historical. We can trace the history of those things and see absolutely how good and important those things were in the past. And I want to say this, and I want to be absolutely clear about this because I think this point might get lost. Physios have adopted this idea of a body as machine, of treating the body objectively in a detached way for more than 100 years. And for most of our history, that's been fantastic. It's seen the profession grow enormously. And it's given us great social standing. It's connected us with the medical profession. It's given us legitimacy. It's provided us with a kind of justification to be the agent of the state when it comes to things like rehabilitation. It's been so important for us. And it's worked up until the 1970s, when the economy of healthcare started to change, when the way that physiotherapy had thought the health system would work started to turn. And since the 1970s, we've seen the growth of a whole range of different things in healthcare, a whole range of different issues, discourses and ideas. And our approach is still stuck in the pre-1970s world. And perhaps the most important reason for that is this thing here. This idea that I talk about, the physiotherapy paradox. And it's quite a simple idea. We are used to treating the body of the person in front of us. And we never had to look up and think about the broader health issues, the cultural or the psychological or the environmental or the spiritual or the intersubjective or the philosophical or the social, all those other ways that people think about health. We all think about health as people. We never had to look at that stuff. We were just concentrating on the body of the person here. And because of that, when the world around us changed, we were never taught the vocabulary to know what to do about it. So we're all sitting in here now, feeling like we don't know the answers. And that's because we've trained ourselves not to know the answers. We've trained ourselves to do this, not to think about the bigger world of health. And because those things aren't in our curricula, they're not in our scopes of practice, they're not legitimised by what we do, right now, we can't see how to react. We can't see how to answer these problems. We can't think about how physio might change. We are stuck with going back to what we know. And this is the physio paradox. Because of our successes in treating the body as machine, that closed off the importance of seeing the broader health picture, which is exactly what we now need. Hence why these 3 books are works on history and philosophy and sociology. Because we've got to look outside of the profession to those things to find the answers. We've got to look in those places.
It's sounds a little bit like attentional focus, Dave, isn't it?
Yeah, I have a question.
Oh, there's a question.
Isn't that a general healthcare problem, what you're talking about now?
It's a general healthcare problem for a lot of professions that have developed a conventional orthodox Western model of healthcare, yes. Yeah.
So, and because we are part of that,
Yeah.
it makes it extra difficult to change that.
It does, because we still think, and we still are to some extent, reliant on the institutions and structures that has served us so important
including
ways.
the financial compensation system, which is blocking a lot of developments.
So that first section of the book is historical. It ends with looking at the period since 1974.
Mm-hmm.
That period, the main argument there is the economic system is changing and our cultural values around health are changing. And that's undermining all of those orthodox health systems that we used to have. Now, my grandparents, from the coal mines of the Midlands, they believed... Do you want to tell me? They believed in the idea of the phrase, the doctor knows best. Now, in the 1950s, if they were ill, they had a doctor or a nurse. That was their only option. Well, now, you can go to an aromatherapist, you can go to an acupuncturist, you can go to a clinical exercise therapist, you can go to chiropractor, you can go to the local supermarket and buy some echinacea or something and self-diagnose and self-treat in ways that my grandparents could never have imagined. The options that are available to us. Added to that, people are much more sceptical about orthodox healthcare. People don't trust doctors like my grandparents did. The thalidomide trial issues, the Tuskegee syphilis issues, the scandals that medicine has caused with things like Harold Shipman. You might know that name. Britain's biggest mass murderer was a general practitioner from Manchester who poisoned 300 of his patients with morphine just after they'd signed their wills over to him. The scandals around medical practice have gradually chipped away at people's faith in medicine. And the fact is that we have a lot of illnesses that we thought had been eradicated coming back now. And medicine doesn't seem to have that many answers. It's desperately looking at things like gene therapies in the way that it looked at antibiotic therapies as a kind of the golden tool that will bring them back into the top of the tree.
Is that for just medicine or also for human behavior?
Do you want to ask that again?
Is that just for the healthcare that people look like that, or just the normal people thinking about when you see conspiracy theories and such kind of things? So people are way more suspicious.
Absolutely,
yeah.
Absolutely. Zygmunt Bauman, who's who's called the father of postmodernism, he said, "We now live in a time where it's like we're all flying in an aeroplane at 30,000 feet, and we think there's a pilot, and then we realise there isn't. And we all feel that sense that we're a little bit rudderless, and things are a bit catastrophic, and we're constantly hearing more and more messages about climate change, about political disruption, about terror, and these things become overwhelming. And we have, all of us, to some extent, lost a little faith in those orthodox figures that 50 years ago taught us, said what was right and wrong. Who these days has the faith in, say, the Roman Catholic Church that was there 50 years ago because of the scandals around child abuse? Who now believes and trusts the legal system or the media or the political system in the way that people used to? We live in a time of much more scepticism, and particularly scepticism towards orthodox figures. Now, physio is an orthodox health practice. So it's not surprising where they go, we go. Which kind of goes on in the book to talk about then, well, what changed? What started to break things for us? Things were going along beautifully through the 1940s, 50s and 60s, and then something happened. And it's these things that have happened since the 1970s that are fundamentally disrupting how people think about physiotherapy. The ageing population, there is work being written about that, as is the burden of chronic illness. Unaffordable social welfare, you'll find very little in physiotherapy about that, but there's tons about that in healthcare generally. The democratisation of knowledge, the fact that now YouTube is the primary source of information for most of our physio students. And it's free. Managerialism, distrust of orthodox practice, appetite for alternatives. These things all happened in recent times, and they are having a direct effect on us. So what's the problem then? Well, I think I've kind of already tried to argue that the problem is the very approach that did so much good for us is now causing problems. This idea of the body as machine, thinking about the body as machine. And it's everywhere. It's everywhere in physiotherapy. In all of these places, the body as machine is king. And I use king very much in a gendered sense because the body as machine is a very masculine, Western, industrial idea about how people should be treated. We pack in our students' training with anatomy and physiology and pathology and biomechanics and kinesiology, and we say these are core subjects and they come right at the start. Why? Why do we say those are core subjects? Why have we not got stuff at the start of the course which is actually more about people, rather than bodies and muscles and bones and things? When we distribute our professions into different medical specialties like muscular, neuro and respiratory, we're taking a medical reductive view of the body, taking a whole person and carving them up into body systems that suit medicine, but they're not real. They're not how people experience health. And increasingly, when people are coming to us as our patients, they're trying to find ways of understanding their health, not in terms of just their bones and joints, but about the misery of the last 3 weeks of the pain they've been in and the disruption of their work patterns and the fact that they can't move around as easily as they could and the kind of existential angst of it and the fact they're going to lose their job or their ACL rupture means their rugby career's over. It's just the complexity of the stuff can't be captured just by treating the body as machine. Our fixation with acute illness and injury, fixing the broken part and returning them to normal. All of our funding models, as far as I understand it here, are similar to New Zealand, insurance-based or private practice-based. They're all based on the idea of a quick diagnosis, treatment, fix, discharge. Well, the kinds of treatments you can do in those short episodes of care are very easy for other people to take. They're very easy to standardise. If you can put a standardised treatment plan together to do that, then somebody much cheaper to train and employ than you could do it. And very quickly we're starting to see things like AI and robotics starting to come into that space as well. It's in the way we teach students and ourselves how to look at bodies. It's in all of our objective testing and measurement, and it's in our focus on clinical trials and RCTs. I honestly believe that we do not need another RCT looking at hamstring stretching. I mean, I'm sorry if you're doing major work on that space, but given the vast volumes of stuff that we need to think about as a profession now, another trial on hamstring stretching could probably wait. And at the same time, we're having a real difficulty with these things down here. And the most problematic aspect of this is these are all things that are representative of 21st century healthcare. The very things we're having a problem with. Hence why the book is called The End of Physiotherapy. Because the argument that I'm making is if we can't lift our heads up from this body of machine in front of us and engage with a broader sense of health and find a relevance for physiotherapy in that space, then we really are in trouble. But here's the thing. I know of thousands of really experienced physios, and most of them have actually worked this out. To be a good physio, you have to be able to understand this. You have to be able to do this. You couldn't survive otherwise. I know tons of physios who do this, but there is no recognition of it. There's nothing in our curricula for it. There's nothing in our scopes of practice that says we claim it as ours. There's nothing in our research that defines it. There's nothing in our language that says these are all parts of physiotherapy already. It's as if we can't face it, we can't define it, we can't look at it. And it's because we don't have the language. And we don't have the language because we've been stuck here. This is the Physio Paradox. If I could show one more slide, and I'm going to shut up for a minute.
Yeah.
Although it's unlikely I'm going to shut up for a minute.
No, you're not going to shut up.
I wanted to show you this because I thought this was really interesting. At my home university, we were looking at the way we assessed our students on clinical placements. And what we did was we had a sort of a sheet that when the students were on clinical placements, we ticked off certain competencies. And some of those competencies were sort of broken down into parts. And during the course of their placement, they would get ticked off for these things. Now that worked really well when you're learning about skills. Like if you want on this placement to learn this particular technique, you can break it down into a number of boxes and you can go tick, 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 done. It doesn't work so well when you're dealing with all of the other stuff, the humanistic side of practice, the empathy, the caring, the flexibility, all of that. Because it's not so easy to break down into little tasks and tick off bits. Oh yes, you've shown me A-level grade empathy, tick. It doesn't work. So we were trying to find a different way to assess that. So we took all of those kind of human traits out, and we said to the placement, the people on placement who are taking our students, give us 3 words. 3 words that mean something to you about the way you practice in your area. So let's say you have a physio here who works in the intensive care unit and another one here who works in an elite sports clinic. We said, right, you give us 3 words that explain how you practice. And maybe for that person it's about thinking quickly on your feet. Maybe it's about compassion for the family. Maybe it's then also about being able to liaise with this multidisciplinary team. That's their 3 words. And this person over here was about motivating the person, but also risk, the risk that they're going to relapse or collapse. And then another thing is maybe really clear instructions. So 3 people, this person here had 3 different words to that person. So we had about 100 clinicians around New Zealand taking our students who all sent us words. And during the course of the year, we collected them together. And then what we said to them was, during the placement, explain to the student what those words mean to you, why they matter to you. Show them, model it to them, and then at the end of the placement, say whether they've worked it out for themselves. Not copied you, because they've got to find their own way. If it's about, say, having empathy for the family, show the student how you do it, and then see if they can develop that skill as well. Nurse them through it, show them how to do it, and then grade that. So no tick boxes, just have you done it, haven't you done it? And we asked them to send us the words. This is what they sent us. This was 1 year. There isn't a duplicate there. And then we just picked out some of these words. Now, I think you would all say that these are important for our students to develop, for us to have, but these are just 6 of what ended up being hundreds of phrases and words. But what was really interesting about this is we looked at our curriculum and said, where is building rapport in the curriculum? If these clinicians are saying this matters, where are we teaching it? Where are we introducing the idea to the students in year 1? Where are we staircasing this and building on it and growing it? Just like we do with, say, the anatomy of the arm. We've put so much energy into that and teaching them all the details, and we've got a clear idea of how we teach it and how we develop it and how we build it into a clinical sense and then introduce it to the students with case studies, and then we give them real patients in safe scenarios, and then they go out into the real world. We've got a model for that. But what about adaptability? How do we teach that? And yet the clinicians are saying this really matters. So this is kind of telling us that these things are what our clinicians say our students need. But I'd challenge you to look at any one of these words on here and say that we have a system of teaching and developing that in our students. It's like we just expect it to happen by osmosis or something, like it's just going to happen in some way. The reality is, of course, that with the good clinicians it does. A lot of these things emerge from experience. But I don't think you should learn those things despite your curriculum or despite your profession. You should learn those things because you are a physio. You should learn to be adaptable and compassionate because it is implicit in your practice. None of these words appear in the New Zealand scope of physio practice, by the way. There's plenty of stuff about the origins and insertions of gracilis, but not so much about building rapport. It's a problem for the whole profession internationally.
Actually, Dave, based on this question, might it be interesting that when we're now sitting here and we think about our profession, about the words, can we come up with some people that you come up with the 3 words which are important for you if we talk about our profession, so that we kind of share it with each other a little bit, that we start thinking. So if you should describe our profession in 3 words, what are the 3 most important parts? Isn't it? So then we just can kind of look upon it a little bit, so we also have a little bit of talking time and sharing time.
We thought we'd do a little bit more around this idea for about another 5 or 10 minutes, and then we'll take a break for a coffee and stretch your legs and stuff. So I'd be quite interested to hear a word or 2 that you think is implicit in your work. If you were with a student and you wanted them to understand something about the intimate nature of your work and the special nature of your work, and you had to limit it to a word or a short phrase, what would it be? Just give me some examples. I'll throw the... Who wants to have the... Oh, I'm going to... My All Blacks technique now.
I would say sensing.
Sensing.
Yes.
So how would you model that to a student? I mean, they're just going to have to watch you doing something to get a sense. They're going to have to work out what you mean by that. How would you do it?
Show it in practice.
How would they know it when they saw it?
The interaction.
Yeah. Because you're talking about something that's going on in your head. You know, you're seeing something that maybe they can't see because they're a novice.
Yeah.
So how do you... I mean, this is what I think the genius of education is. To take an idea like this, which is incredibly complex and situational, and work out how we can convey that to a student in a way that means they can go, aha, right, I see why that matters.
I had a similar situation today. A novice colleague joined me in a session with a patient. I did what I had to do with the patient, and I asked him to reflect on it, and his reflection allowed me to respond to that and add my ideas about interpreting what I sensed.
Yeah.
And it took him a step forward, I think.
Well, over lunch, over dinner, we were talking about the ideas of embodiment and Merleau-Ponty and some of the phenomenological research that's been done for the last 100 years. Sensing, intuition, that sense of understanding something has such a rich, deep philosophical history. There's so much beautiful stuff written about it. You won't find any of it in physio. But why? Why is it we can't claim that and understand it better and dig deeper into it? I don't know. I think it's a beautiful example, thank you. Another word? Pass the ball, the cube along.
Communication.
Communication.
In the right way.
Yeah.
And there's so much in it as well, of course.
Yeah. So if I was your student,
yeah.
what kinds of communication would you say for you personally in your work matter most?
Reading the body language,
Yeah.
because words are such a small part
Yeah.
in communication.
Yeah.
So I would teach them about reading the body language and also using the body language of yourself
Yeah.
in the therapy relation.
Could you do it without words, given that you're saying words have their limits, they fail us often when we come to look at bodies? I wonder if there's a way we could teach the students about it.
Yeah, sure.
To put words away, maybe through dance or movement or
Yeah, sure.
Feldenkrais, Alexander techniques, whatever, I don't know.
Just anyway, when you teach students about communication, it's all about experiencing it.
There's a Canadian writer called Erin Manning who's written a book called Relationscapes, which is amazing. And in it she talks about tango dancers. And she says that with tango dancing, and I don't know, you might have worked this out already, but I'm not a dancer.
I did. Okay.
Oh, thank you.
Sorry,
but with
yeah.
tango dancers, there are apparently a very few rules, but when you see two dancers who are good, really good, it's quite the most beautiful thing. And what she says is, if you were to film two dancers together, and you'd play the film back, and stop it at any point, let's say they're in a particular position, at that instant, there are 1,000 things that could go wrong. They could fall over on the floor in 1,000 ways. And yet, miraculously, somehow they manage to resolve that tension and move to the next movement, and it flows beautifully. And what she says, one of the things she talks about, is the idea she calls pre-acceleration, which is that at that instant, with 1,000 possible things that could go wrong, they manage somehow to remove the 999 that were going to be problematic and settle on this one. So all of the action of movement, all of the thought and the problems that movement poses are actually worked through before they actually move. The movement is the end result of all of that thinking and problem solving. It's the death of it, in a sense. It's the conclusion. It's the point when you don't have to think anymore. And she relates that to learning. It's a bit like when we studied, I don't know whether you were like this, when you had anatomy exams and you crammed all night to remember all of these facts. And then the exam paper came out in the morning and you opened the page and you realised that there's a whole bunch of things that you now didn't need to remember because they're not going to ask you. And of course, 10 minutes after the exam, the students forgot everything with anatomy because they didn't have to remember that. So they crammed it all, and then as soon as the exam was done, it was dead. And she said it's like that, which is why there's always a problem if you close things off, if you resolve things. She says that's the problem. By resolving things, that kills the energy, it takes the juice out of it. The juice and the life of the tango dance is the fact that in every instance there's 1,000 things that could go wrong. And we feel it, that tension is there. That's what makes the dance alive. So the thing that makes therapy live, the thing that makes learning live for people is not answers. It's the absence of answers. It's the fact there are 1,000 things in play that they have to resolve. And yet so much physiotherapy is about coming into the room already starting to think about the discharge plan, the finish, the closure, the end of, the diagnosis, the labelling, the giving the name of, the treatment, the going home. So much of education is about preparing the students for an exam, giving them an exam, and then we know that they're going to forget everything that they learned 20 minutes later because they've passed that standard. Keeping things alive is about not providing answers. One of the biggest comments I get from people who've read the book is they want me to tell them the answer. They want me to say, so what's the answer for physiotherapy? And of course, my answer is, I want to open up physiotherapy to 1,000 possible alternatives. I want to do what Erin Manning's done and turn physiotherapy into a tango dance where there's 1,000 things that are alive. I want to stop us killing things. I want to stop us saying that the answer to physio is X. So tonight, for instance, one of the things I would love you to go away with is not a sense that, oh, right, I know the answer now. I want you to go away thinking, right, now there's 1,000 things I can think about. There's 1,000 tensions that are live, and they're fun, and they're exciting, and they're relevant, and they're important. And stop trying to answer things.
Yeah, you're really breaking up the perspective.
Trying.
Yeah. Well, it's beautiful.
So is fun to get?
Perhaps a little provocative. We get more and more guidelines in our profession for the lower back pain, cervical pain, and so on. Are you more or less against it? Because
not more or less, completely, totally.
Yeah, because they take away the creativity and therefore the juice out of our profession.
Absolutely. Now, I know I fully understand...
I'm your fan already.
I fully understand that there's economic principles behind this. You know, for some people it's their livelihood. It requires them to fulfill these requirements. But at every opportunity we have where we can remove a rule, where we can take away a standardized process, where we can stop that. I'm an educator by training. I work in a university. I teach undergrad and postgrad students. In one of my big courses that I teach postgrad students, which is about health professional practice, I've taken away all of the university's rules. There's no restrictions on how much they write. There's no word counts. There's no, you have to write it in Times New Roman size 12 rubbish. There's no submission requirements that the university wants, because every time you impose a little rule on something like that, you kill something. You kill something.
Dude, just to interrupt, I was 2 weeks ago, I was in Cambridge on a meeting concerning mind lines, which is kind of clinical mind lines, the things that we have in our head, not the thing that is written down. And it was with some medical doctors and nurses, and they come with a story from the NICE Guideline Institute in the UK. And the director of the NICE Institute, he got a phone call in the middle of the night. So he was passed through. It was a doctor in a hospital who said he had a patient who didn't fit in with the guideline. And he asked him, what should I do? So it went all the way up. And in the Guideline Institute of the NICE Guideline, they came to the conclusion, okay, this is not really what the guidelines were intended to do. So we moved into the wrong track, because now people don't dare to take decisions, as you say. So we have to go back. And also on that level, they start to think, okay, we might have taken the wrong turn somewhere. And I think that's actually the thing with creativity. We kill it by putting it too much into rules.
One of my, there's a thing, I'll come in a second. There's a psychotherapist of old, Bion, who some of you might know. And he had this lovely phrase which he said to a patient once who was getting cross with him because he wouldn't tell her what to do. And he said, I don't know why you're getting cross with me. I wasn't trying to help you. And I think, you know, there's something funny in that. But there's also something in about the therapeutic relationship there, about how we've created the conditions where the patient comes to us for an answer. That is one of the most dangerous situations to have in terms of a power dynamic and an expectation. That idea of, don't get cross with me, I wasn't trying to help you, is a really, really interesting kind of way to think about therapy and practice. Doing things differently, keeping spaces open for creativity and imagination, for patients to find new solutions for things, creative new ways. There's one of my favourite philosophers, Gilles Deleuze. He has this lovely ethical framework where he says, every time you open a space for diversity and inclusiveness, it's good. Every time you close that space, it's bad. Simple as that. So every time you write a rule for somebody that says you must do it this way, that's generally a bad thing. Now that creates all kinds of problems in itself, and all kinds of tensions and all kinds of insecurities in our minds and things. But those are the kinds of things I think we should start working through. Those are the kinds of things that creative people, designers, architects, artists, the people who are creative in this world, whose livelihoods rely on their creativity, that's the kind of stuff they engage in every day. Wouldn't hurt us to try some of that maybe, instead of being so rule-based and disciplined. There was a question at the back, but you need the
catch box.
What? Oh my goodness. Oh, beautifully done.
Definitely.
I'm lucky, I think, because I'm a little less. I have a little less restrictions because I work a lot with children, and it's much easier to get a little bit from the guidelines.
Yeah.
And my word would be a flexibility to see what it can change during your treatment. Where the important things are. It's not that you, of course, you start with something, but you can change it during the therapy. And I think it's, I'm lucky that I have this possibility to do it like that.
We did some work with a good friend of mine, Bob Gibson, who's a physio, somebody you might know from Toronto in Canada. And we were looking at the words that physios use for things, and trying to be playful and doing some funny, just being funny with these words. And flexibility was one of the words we came up with. We made this list of words that are in physio textbooks. And if you look at them, so many of them have double meanings. And physios only take very narrow views, like the word balance. Physios, for us, it's about centre of gravity and displacement. But balance in life is a very broad concept. It's a very big thing. So we were kind of saying, well, why is it physios are only interested in that bit? And if you think about all of the words that you use in physiotherapy that are specific, they all have, well, many of them have a separate other meaning. And it was all working fine until we got to the word abduction. And then we started looking at people being abducted by terrorists, and we thought, okay, that's probably a bit too far. But we were thinking particularly about the word movement. So many physio professions claim the word movement. They say that's what physio is. You ask a lot of physios what one word, many would say movement. But in fact, movement is a very broad idea. Movement goes from the very tiny osmotic cellular movements of fluids across cells and atomic movement, right up to the grand social movements of migrations and diasporas and mental, movements of, say, feminism as a movement, and just broad ideas and everything in between. And yet, if you look at the history of physiotherapy, we haven't claimed any of that. We've just claimed elbow flexion. Like this bit in the middle is about this big. But why? Historically, some people made some decisions way back that we were going to only take that bit because that's what made the most sense at the time. But if the world has changed, why can't we claim a different meaning, a broader view? Now, I'm not suggesting we're going to take over atomic physics or we're going to become the specialists in migration, but we could at least look and say, surely what we do is more than elbow flexion. And in which case, what is it? So playing with some of these words and doing funny stuff with them is a bit silly on the one hand, but it's also deadly serious on the other hand, because it's making us ask creative questions about, well, where could we go? Do you think?
Yeah, okay, yeah.
Oh, sorry, there's another question.
Yeah, thank you. I have a question about the identity of physiotherapy, because I think if I bring a little nuance into the field, I work at an education institution for physiotherapists, and we work really hard to get that broad perspective of looking at clients' problems in our curricula. And we see a little bit of a shift between colleagues as well. Some of them are really biomechanical still, and others are more in the broad perspective. But the discussions we often have among colleagues, then they say, what are we then as physiotherapists? Because I think a lot of physiotherapists want to change and really see the broad perspective indeed with patients' problems and health problems in society. But what is our identity then? I think the fear of losing identity might be one of the inhibiting factors.
Okay, so first of all, you're talking to somebody who's written a book called The End of Physiotherapy. So I should qualify what I'm going to say on the basis that I think I probably have quite an extreme view. And a lot of the principle behind the way I work is trying to write ideas that are out here, so it creates some space for people to do other things that are maybe not so ridiculous. In principle, I think the problem is with the box that we have defined the profession in, which we call physiotherapy. Now, we know that physical therapies have been used for millennia and will always be needed by people. I don't doubt for a moment that however good robots get, people will still always want physical touch. They will still want somebody who can look at the way they move and work out why things are going wrong. I think they will always want physical therapies. I don't doubt that. The problem is, I think, that we've created this monument, this edifice that we call physiotherapy, that we can't seem to break. We can't seem to dissolve the edges or move outside of it because we don't know how and because we're trained in a particular way. So the reason the book is called The End of Physiotherapy is I genuinely believe that we may have to dissolve that idea of physiotherapy, the way that our registration boards have defined and says you can't do this, you can't do that, so that we can create a form of practice that does allow us to do what the public needs. And I've got a slide here which I won't show you because I can tell you. It asks the question, if it was in the public's interest to dissolve physiotherapy as a profession, would you do it? Now, I've asked that question of a lot of my colleagues, and sometimes you can see them thinking about the question, would I, wouldn't I? Which to me feels like that's part of the problem. Because, of course, we would dissolve physiotherapy if it was in the public's interest. But we are so locked into the idea of preserving physiotherapy as a profession, we sometimes lose sight of the fact that our reason for being here is to help people. And if it takes us dissolving the profession and creating something new that does that better, then I, for one, have no problem with that. I am not about keeping physiotherapy alive as a profession just because it has this glorious history and, like the Roman Empire, should continue forever. Our job is to help people. And if we can do that better in a different shape or form, and we're restricted from doing that by our registration bodies and whoever else, because thou shalt not step outside, then that's the time we've really got to be looking at that and saying, we are serving ourselves, not the public. Sorry, Joost.
But isn't this how social processes go? Because things change and then systems change because the things change.
Yeah.
As you talked about 1950 when the doctor was the guard of the social system and that was very functional. Yeah. And now things have changed and so the system has to change. And the system is always behind, the medical system in this case, is behind the changes, the societal changes.
Yeah.
So isn't this just a natural way it goes?
Maybe.
Which we should stimulate, of course.
Yeah. I think that there's so much institutional wisdom in physiotherapy. There are so many people in physiotherapy who've got years of amazing practice experience. I would love to think we could actually do this consciously and thoughtfully and carefully as a community, and not just have this tidal wave of change sweep over us and then us, wonder what happened. But to do that, we've got to break out of this kind of traditional way of thinking and lift our eyes up from the patient in front of us. So that's my project, really. That's my attempt. If we can find 1,000 new ways to talk about physiotherapy, then I think amongst all of us in the room, I guarantee you there's nothing in the book that you would be surprised by. You would all say, I can recognise that, I can see that. The point is you're not really allowed to claim it. I want us to be able to claim it. I actually think I want our registration authorities to step away quite a lot. I've got another slide on there which is of a little girl climbing up the Berlin Wall before it was knocked down. We have a really interesting attitude to people who are rebels. In some contexts, we love it. The idea that somebody might challenge the East German government and knock the wall down, we think is great. If change involves breaking the old to create the new, what should we do with practitioners who break the rules? At the moment, anybody who steps outside physiotherapy is struck off or sanctioned. That doesn't seem to me to be a very adequate way of dealing with new ideas. Now, I'm fine about malpractice and abuse of patients and things like that, absolutely. But I'm talking about people who are trying to find creative ways to think anew about physiotherapy. We have to have some kind of mechanism in place for people who are doing what are called bleeding edge practices. I don't know how that is in the Netherlands. I would love to think that you've got people who are stimulated in that way to do things that are funky. I was talking, a colleague of mine in the UK, she's a physio and a ceramicist. And she uses her physio experience to work with patients using ceramics. I think that's just amazing. Now, she can't work as a physio because nobody in the UK will register her for that kind of work. It's outside of the scope. So what does she do? She leaves physiotherapy and she goes and does it without that license. Why can't she practice that skill, that craft? She's a genius. So this is an issue for us as well, you know, the way we're policing our boundaries at the moment is a problem.
I think this is a nice time to stretch your legs for 5 minutes. Would it be? We have a question first.
I have a question.
Yeah, please.
Yeah. Why do you think of expanding to other areas or other material? Or why do you not think in shrinking back to what is really the essence of physiotherapy, going back to the roots, stop with all the extras and all kinds of non-physiotherapy treatments, go back to where we belong and make clear to the audience and to the patients what they can expect from us as a professional?
That's a fantastic question. Now, I've mentioned a lot of the sort of articles and stuff that I've written about tonight. I'm happy to provide you with links to them all and send you copies of them all. But I wrote about this with a colleague about the New Zealand context in 2005 in a paper called Possible Futures for Physiotherapy. And we talked about 4 ways that physio could go. The first way was that we could just sit and wait, not change, just watch and see what happened. And we thought that was a good idea because that meant that we weren't reactive and when things change we could respond accordingly. But we thought that was a problem because we might get left behind. So then we thought, well, maybe the answer is we go back to exactly what you're suggesting, which is to go back to our roots in the biomechanical, the biomedical, the body as machine approach. Now that has a real appeal because it's a very identifiable profession. We can sell it, we know what we are. The downside of it is that the world has changed and that people are expecting more from their health professionals than that kind of what Donald Schoen called a technical rationalist. That healthcare has become much more complex than that idea, and that work, that more complex work, will be given to other people. And we'll gradually become quite marginalised as being specialists in that field. And that field is work that can easily be replicated by other people. So that's a problem with that. So the third option we looked at was throwing the baby out with the bathwater. You know that phrase you know about, just throw the body as machine away and become some kind of new Renaissance rehab worker that didn't have an identity but just floated freely around and just did everything. Well, that was great because it's responsive and it's like the kind of postmodern healthcare that people are now expecting, particularly governments and funders. But the problem is with that is you lose your identity. It's hard to actually say, well, that's a physio, or to know what you are. It's hard to argue for funding for that kind of person because you're trying to be all things to all people. So the fourth thing that we said was, the answer is clearly to keep the best of the old and incorporate the best of the new. And then in a paper we wrote afterwards that followed on from that in 2008 called Crisis, What Crisis? We said that that's also impossible. Because if you know anything about philosophy, you'll know that the principles that underpin Western biomedical science are exactly antagonistic to the principles of the philosophies of the humanities and social sciences. You cannot just bolt one onto the other. Because you'd end up with teaching the students in the morning about the importance of anatomy, and then in the afternoon you'd be teaching them, no, anatomy doesn't matter at all. And you end up with a 17-year degree and a very confused student. So, in fact, none of those 4 options are easy fixes.
Yeah, where I don't agree with your study that you did on the 4 roots, is that if I understand you well, you say that if you specialize in your profession, so shrink the outside, shrink back to where you are really good in, then you become marginal. I don't think that's what we see in society.
No.
Either in shops they specialize, restaurants they specialize, medical field, doctors specialize. They become a super specialist on this kind of cancer or that kind of orthopedic problem. So everywhere you see specialization being the route to the healthy future. So why did you conclude that you become marginal?
I think the idea of specialisation and increasing expertise is really popular these days as a way to answer this problem. One of the problems for physios is going to be answered by us becoming more and more specialised, by having more master's entry and doctoral entry degrees, by people coming out with doctoral qualifications, by having more and more elite specialisms. The biggest problem with it is economic. If you go through a lengthy doctoral training, as now been really discovered in the States, then students come out with a big debt, and they also have high expectations of a salary bump. So they go out into the community expecting to charge higher rates for their care. Well, that's fine as long as you only intend on serving those people who've got money. But 80% of the worst health is amongst people who have the social determinants of health about poor housing and poor educational standards and unemployment and poverty and things. That's where the most comorbid health problems are that the government is worried about. They're not worried about the white worried well who will come to those expensive physios for a short 8-week treatment. So if if its model is to become more and more specialised and expensive, it's going to exclude itself from huge swathes of the population, particularly that area of the population that governments are interested in responding to. So if then the government gets the idea that physio isn't interested in responding to those things, then we will become niche and specialised and pushed to one side and left to those people with short-term, acute, self-limiting conditions that they'll pay 8 sessions for to get treated. Now, that's exactly the kind of clinical problem that is much better treated by someone who's much cheaper than us to train and employ, or a robot, or an AI. So the specialisation works if there is also a model of democratic physiotherapy behind it that treats the stroke patient, the person with chronic lung disease, the person who needs long-term cardiac rehab, the person with multiple comorbidities. Specialisation won't do that. So specialisation is a good thing, but only for a section of physiotherapy, and it cannot be the model. We have to find a model that works for the population of need out there, and the population of need out there is not ankle sprains or ACL ruptures. It's peripheral vascular disease with some depression and right heart failure and chronic diabetes and the kind of health problems that really do require somebody with our kind of level of training and experience to work with, because nobody else, I wouldn't trust anybody else with those people.
Okay, thank you, you're back again. Just to elaborate a little bit more on, we've been thinking, well, as you see, we didn't make a clear presentation. So that was also not the intention. So we want to try to make it as adaptive as possible, to be flexible in what are the questions. So that's how we kind of jungled a little bit. So we came up with the ideas about reality, what we are kind of talking about. We still are thinking in teaching, in rules, in reality, going back towards more towards the past, our past as physiotherapists, what are we good at? But at the same time, what we also know at the moment, our reality is changing. Our profession came from a past in which we had one physical reality and maybe a religious reality. In this moment, we could say that every human being is in itself a cyborg. Most of us, we live simultaneously in the real world and in the virtual world. So the virtual world in itself is already there. You can't disconnect it. I would say that some of the students and some of the people around us are living maybe more in a virtual world than in the physical world. And also a lot of the feelings and the happenings are there. So their embodiment might even be more in the virtual world than in the physical world. And that crosses over somewhere. So we as physiotherapists do really recognize the virtual world already there. Like we see now, you have cyborg anthropologists who understand also that the anthropology of the human is a little bit different than from a cyborg. And actually, in that sense, we all have here mobile phones. I see a lot of pictures, text messages, quite a lot of things. So we are dealing with this virtual world. So in itself, maybe we are already cyborgs around here. And if we are cyborgs, then we have different realities. But if there are different realities and we can only already tell two, the virtual and the physical one, might there be even more? Because those are the ones we can sense. So then something gets a little bit blurry. I really like the work of Albert Camus, the French philosopher and writer, who starts with the absurd. He likes the absurd world, and he also always takes an absurd proposition. He started with one of his books about the strangeness, that he looked upon the world as if it is strange for you. So don't look upon the world as you know it, but look upon this world as if it is something that you have never seen before. If, for example, we look about our healthcare system, it's kind of funny, isn't it, that you need a referral and people start paying, and the meaning of money in itself. Imagine that you can't recognize it, money in itself. Why do we have money? So we give some kind of paper to about somebody, and then you can do something with it, and people collect paper. Why? It's absurd in itself. So there's a lot of things that are actually absurd. One of the stories from Camus is about Sisyphus. Sisyphus is the myth of Sisyphus. He was punished by the gods because he did something wrong, and his punishment was he had to roll up this rock up the mountain every day, and then at the end of the day it rolled back, he went down the mountain again, and he did it again. And that's for eternity. And he hated this work, and he really disliked it and everything, which is quite common, of course. And some of us, because I've been talking to colleagues who liked their work as physiotherapists, and some get a little bit disappointed and angry and fighting it. But in itself, what the myth of Sisyphus is about is that he's saying, actually Sisyphus starts to love his rock. Because the moment he starts to love his rock, because that's the thing he's doing. You don't have to challenge, you don't have to fight that that's your role in life. The moment you accept it and you start to love it, you can see the tiny little scratches around it, around this corner, and you start to see about the beauty of it. Actually, what Dave was saying, what are the three major words of your profession? So we can say that's the profession. We love our profession, that's why we're here. That's also why it is so much ingrained, because it feels like that's our role, to roll the rock of physiotherapy up the mountain every day, and sometimes it goes back and we push it up again. But what is it actually that we love? And if we know what we love, we can go further. And if we don't, sometimes we are kind of, this rock, this mountain that we have to push up, that might be the rules. But where does these rules come from? From an absurdity perspective, I would say those rules are nothing in itself. They're just solutions to problems from the past. And those we expose towards the future. But the moment we start questioning those rules, we really get somewhere, because then we can think a little bit more freely. So don't expect rules because they are rules, or they are norms, which may be even worse, but that's a different story. But the moment we start to see rules from a different perspective, we can think, oh, okay. So rules is something maybe we can just have a perspective on. When we look on the perspectives on the world, then we can see the same thing from different viewpoints, like with the fish. One looks at it as a toy, the other one looks at it as food. It's the same thing that we look upon the world. And of course we can talk it about ontology. It's the way how we look, what is the world to us. And most of what we will say, it's the empirical world. That's also the science brought it, that we say this the world is how we can sense it. That is our world, how we can see, touch it, that's the real world. And at the same time we understand, especially when having also a virtual reality around it, there's also an actual world. That is the world we live in right now. But maybe there's even a world which is more a real world. There's even a world we can't even imagine at this point. Well, that makes it hard to think. So still, what is the rule? Why do we think that the world is what we think it is? Why does the world have to be empirical in itself? Is that the only world? And does it really limit us to think in that way? Because the moment we can see a little bit broader, it brings on chaos in itself, but also it gives options and better paths to look upon the world. When I look, and that's a little bit weird, of course, but I'm a little bit chaotic, or chaotic maybe, at best. Chaos is also a kind of structure, that's what I would love to say. And if I look at the things, then a lot of times you see a mandarin. If we look at our profession, this is our square, or actually maybe this is the manual therapy square, this is the pediatrics, and this is the cardiorespiratory, this is the neurologics, and this is the geriatric. Everybody has a square. And actually, those squares don't touch because we have lines in between. So, ooh, be careful. So, this is my corner, that's your corner. And that's constantly what's working out there. And that's also how the medical profession looks out. That's also what I see sometimes in our curriculum. See, this is anatomy, and this is physiology, and then we have to integrate it. But at the same time, we present this one and make sense of it. But at the same time, we could also order the world like Jackson Pollock does. It's one big mess, but in itself, if you look a little bit closer, you see new connections, because the connections can emerge out of nothing. And those connections in itself bring up a new world. It's the same, imagine that we think about physiotherapy as we have ordered it right now as a shelf with books in it. And we bring down the whole shelf with all the books, and all the books are on the floor, and we can start reorganizing them again, based on different principles, because the principle of organization is the principle of order that we bring upon it. And sometimes when we use the order of the past, that doesn't mean that we can bring up the order of the future. So sometimes we have to organize it to bring it in a new perspective. And that new perspective in itself can come up with new solutions. Because at the moment we keep on doing what we did, so the solutions of the past might not have been the power to be the solutions of the future. Because the future is different. And as we already saw, we have different perspectives on the future. So nobody knows the future that much. And are we literate about the future, or are we a little bit more illiterate about the future? So what's the future? What do we think? What kind of assumptions do we have there? And those assumptions actually bring us towards the future. And that gives us a kind of our way. How do we think about things? Can we look upon things in a more unstructured way? That connection might be interesting to look upon motor learning or motor control, which is kind of at the heart maybe at physiotherapy. Some of us look at motor control, and that's also one of the theories that we all know, that we look at motor control like there's a central processing area who controls everything. So the body is just a puppet on a string, to make it more in an easy way. Or it's more a dynamic system, which connects us and gives us a kind of degrees of freedom. The only thing what we have to do, we have to find these freedoms. So this is a liberating thing. This one, it will be hard for me to liberate. So what's right? I don't know. I know at least what I prefer. I prefer this one, by far. But that gives a kind of an option for new possibilities and solutions in itself, while this one creates, to my opinion, more as a central theme which I can't escape. And I want to find that escape room in there to go to the next step. So I want to find the door in the cage so that we can go to the next step. What is there? And if I look to physiotherapy, it's one of the art forms that this is one of the big pieces of art which is connected in the Ludwig Museum in Köln. And then we see, of course, we see the big car that was there. But actually what we most of the time we don't see is the people right here in the back who are enjoying the view and the nature. Is that not something sometimes in physiotherapy? That we see so much of what's in front of us that we forget to look what's behind it. Where can we go? So what different views are there? Is physiotherapy really about the body in itself? Or is it in a broader perspective? Can we think about it differently? So imagine that we take our own rules and assumptions away, and we look what's more in it. Is there more than just the body? Is there more than just the object? Is there subjectivity? What can we find? So that in essence, it's not about so much about right and wrong, because that's also just words. What are the good? What is best? Or is it more a spectrum of different positions that you can take? And that we can have a different position on things. We all have a different position. We like to see that we have what are the similarities between us. But maybe we have to focus way more on the differences first, so that we see what are the different objections, what are the different subjects that we look upon it. And if we know the differences, we can afterwards find the similarities, but then we start to understand each other a little bit better. But we always think as physiotherapists, for example, we are the same. I would say we disagree on quite a lot of things. And if we dive deep enough, we will find this disagreement. But if we love this disagreement in itself, then it gets a beauty in itself, and we see the spectrum, and we see also directly the thing that combines us. And if we can look into the spectrum of physiotherapy, where are the similarities, where are the differences, and what are the new axes? So what is in the center? Where are the really new things that we can go on? And I think it would be nice to start now for the last hour, to start exploring, like they've already put out there, what kind of crazy thoughts can we think of? So instead of thinking about physiotherapy in the old way, we know what we are good at, we know what we like, because we love it, we love that rock. But if we redefine our rock, our profession, what kind of spectrum of ideas can we come up with? So be as creative as possible and embrace the chaos.
I thought it might be quite useful to talk a little bit about methods, methodology. How do you do this? And I wanted to, bear with us a second, start with this. How do you do this? How do you go about shaking things up, changing things? It's one thing to say, you know, we need to take different perspectives, different views, but how do you do that? And so I thought I'd talk a little, just briefly about how I do it and the principles behind how I work. And it's a very simple set of rules, but that might be helpful to you. The first thing is this quote, which I think is absolutely fantastic. It's from a business commentator, David Hanna, who says, all organisations are perfectly designed to get the results they get. So in other words, what that's saying is that physiotherapy's problems now have been designed by us. They've been designed into the way we've built physiotherapy. They're not somebody else's making, they're not accidents of fate, they're not some kind of malign God who's looking down on us and doing nasty stuff. It was built into the problems we now got. The advantages we now have, the successes and the failures are all built into the way we've designed physiotherapy. And so if we want to have a different future, we have to think about designing physiotherapy differently. And remember that physiotherapy is a made-up thing. It's not an object like this pen. It's not a real thing, it's a social construct. And if we chose tomorrow to construct it differently, we could. And I think that power that we have to actually change things is really important. This might be a little bit controversial, but I'm going to, because I know how popular this is at the moment, but this is one of the ways that people are talking right now about changing physiotherapy. This is the Biopsychosocial Model, which is very trendy and very popular and complete rubbish. The Biopsychosocial Model is popular at the moment, and it's come a lot from people who are working in chronic pain and who are sort of bridging into the psychological aspects of health. And that's primarily because that's where it's come from. The biopsychosocial model was a model developed by psychologists working alongside doctors. But in fact, it's not a balanced model at all. The biopsychosocial model is really that. It's still a very dominant biological paradigm with some aspects of psychology, and only those that conform to a biological view of the brain and the mind, nested within it. And actually, the critically important social context that people live and experience health through is still very marginal, still very much on the outside, and really not in the literature. If you wanted to go back tonight or tomorrow and do a literature search on the biopsychosocial model in healthcare, I guarantee you what you're going to find is a massive amount of psychological and biological, the body and mind kind of stuff still being worked through, and the social context of health not being there at all. And so I don't necessarily think that that's the holistic model for us. I think it represents a move towards a more opening of the kind of mental aspects of healthcare to us. But it's by no means a holistic model of healthcare. And so we need to... So the first thing I would say is, whatever is trendy, whatever comes forward as being the latest solution, the first rule I would say to you is be skeptical of it. The most dangerous ideas are the ones that are popular. So your first rule, I think, when you're trying to apply these things, is what everybody else is taking as a good idea, that's where you want to start applying your microscope. The second thing... Oh, do you want to go into that? Oh, no. The second thing that... I'll just jump out... The second thing, that principle I tend to try and apply, the method that I try to apply, is to find the things that are most obvious. To look in the places where things are the most mundane and taken for granted. Don't look for the grand ideas or the big picture stuff. Look for the local and the small. Look in your own practice at the things you just take for granted every day. One of the assignments I set my postgrad students is to look at an object around their clinic space that they couldn't live without, but actually they never really think of, and to analyse it. And I had a physio this last semester who's worked in women's health, and she wrote, she did a piece of work around her clinic door. And she said the door is perhaps the most important technology for her, because the door shuts the corridor off from the public gaze and puts the woman in a safe space. It means that there's privacy and there can be confidential conversations, and she can do the work which is sometimes very delicate and sensitive. And so without a door, if it was a curtain or a partition, she wouldn't feel like that was a safe environment. So taking things that are obvious and everyday is really, really useful. I wrote a paper called Foucault and Physio, which was about treatment beds, that stuff we were talking about earlier on, about why physio treatment beds are like they are. The everyday things are really crucial. That's where the real juice of physiotherapy goes on. And for the last year, I've been doing some work with my brother, who's a photography teacher. And he was visiting New Zealand on holiday, and we were going around the country and doing some travelling and got talking a lot about how photography works. And he was saying to me that photography, which actually has a very similar timeline historically to physio, has for a long time, photography was about documenting reality and trying to capture reality. And then around the 1960s and 70s, photographers started asking about their agency. A photographer would go into a war zone and take a photo of somebody bleeding to death, or a seal cub being bludgeoned, or a famine. And they started asking, well, should we not step in? Shouldn't we help? Or are we just like this objective, detached person who documents what's going on? And they started asking these questions about the person that they were photographing, and particularly about how women were being photographed and how bodies were being represented as models, and the thinness and the kind of idealised woman. And so photography went through this period when it hated itself, because it realised the kind of harms that it was just propagating on the basis that it was objective and detached and neutral. And now there are photographers, for the last sort of 40 years or so, there are photographers who are taking photographs trying very much to not be detached, but to be part of the photograph. And so it's changed the nature of photography. And as we were talking about this, it struck me, if you look at a lot of physiotherapy photography, or the images that are in physiotherapy textbooks, there's some interesting things being done. And I've got my brother to have a look at some of these pictures and talk about them as a photographer would critique them. Now, this is some of the stuff he said about this picture. I've got a few pictures to show you here, but this is Alan Stoddard in a book on manipulative practice from the 60s. And first of all, there's the fact that the focus is on the hands and the technique. And there's quite clearly a power situation going on here. There's a male doing this to a female body. And the fact that she's undressed in the way she is sort of suggests that you have the license to do whatever you like with the body in front of you. You can undress the person however you need to do. You can do this. The focus is all on the technique. The people don't matter in here. And you notice that the angle that the photograph is taken from is what you're supposed to be the third person's gaze looking down on the woman being treated. The idea here is to teach you how to look at the body of the person in front of you. So there's the expert, there's the patient, and the third person you're supposed to represent, the camera represents, is you. And this is how you're supposed to learn to look. And then there are some pictures, a few pictures you'll see in the textbooks, where the subjectivity of the model bleeds through. I think this is a beautiful picture. This is supposed to be about just this. This is supposed to be about the technique, but then look at her eyes and how she's looking up. She doesn't need to look up like that. And the photographer probably was trying to just capture a technique and then accidentally caught this gaze. And you can't help but think now all of a sudden that's a person. That's just not just a lumbar spine. That's a real person. And that then becomes problematic for us, because then what are we supposed to do about that? We'd much prefer pictures to look like this, where this could be anybody, any patient, any therapist. It's all about the technique. Even chop these people's heads off in some cases so that you focus. And really, you can do whatever you need to do to the body. This is what we're saying to the student, the viewer. This is how you're supposed to do the technique. And then again, in another picture here, you get a face, a gaze. I don't know whether you know the classic Brian Mulligan scandal about his photographs, do you? Brian Mulligan, you all know Brian Mulligan, famous New Zealander, lovely guy, wrote his books on nags and snags, and they've gone through about 6 editions now. After the 2nd edition, his American publishers came to him and said, we need you to take some pictures of you doing a particular thoracic mobe on a woman topless. Because there is concern in the States that if they're doing this technique, they might be sued because they're doing something that seems abusive. So he agreed, and he organised, and in the 3rd edition of his book, you'll find 2 pictures which are extraordinary. One of them, and I'll see if I can find it before we go, has a model sitting on a bed, and I'll try and mimic what she's... So the model, imagine I'm sitting on a plinth, she's sitting on a bed, and her head's turned away like this, and her face is blacked out so you can't see her face, got a black box over it. And Brian is behind her with his hands across her chest. She's wearing a skirt covering her legs, nothing on top. So her breasts are bare and his hands are like this across her chest. And it's a black and white photo, and honestly, if you took that photo around the streets of Amsterdam or Nijmegen today and said, where's that from? Most people would say it's from some kind of cheap, nasty porn magazine. Because, the fact that her face is turned away and blacked out, and it's all about this kind of strange hand position and the fact he's obscured behind. The second photo is of her, the same woman, lying down on a plinth. She's on her side, and one person out of shot is holding a leg in slight abduction. And she's lying away, and Brian is at the top end doing something else, and her back is to the camera. But she's kept on black lace underwear, a G-string like thong and a bra. And then she has a tattoo on her bottom, and in one of the pictures the tattoo is there, and in another edition it's blacked out, because the Americans thought that was offensive. Now I interviewed Brian and I talked to him at length about this, and he said, well, in previous editions of the books he'd used his niece and nephew, but he didn't want to use his niece and nephew for these images. So can you imagine what he did? He rang a massage parlour and got a prostitute to come. And she came, she took her clothes off, he did the thing, he paid her, she put her clothes back on and went away. There you go. So this is Brian doing this technique. Now I interviewed him with Rose, his wife, in the room, and she was very prickly about this. She didn't really like talking about it at all. Now you can see... Okay, there's a sound. Now, you can see why, when you talk about physiotherapy and sensuality and the problem of prostitution and sex, I'm not just saying it to be scandalous. There is an issue about bodies and touch and how we teach people about touch. And these are quite rare, but they're not as rare as you'd think. The way that we teach students about that is to project the idea of the body as machine. And I think there are ethical abuses of people when you photograph, like that first image, just somebody with their underwear pulled down and somebody standing over them just forcefully manipulating their back. I think there are ethical abuses going on there that we should not be teaching people. I don't care whether it's just, you're teaching a technique. You could do that in a different way. And maybe by learning about the ways that photographers have gone through that crisis, about how they represent the person in front of you. That could be a way we could teach our students to care for people and show empathy and compassion. Certainly these kind of images don't do that. They say you've got the power to do whatever the hell you like to people. Not consciously, they're not screaming it, but they're subtle enough to say that. I want to... thank you for that, that's fantastic. I want to just finish off with a couple of quotes for me, and then I'm going to shut up. One of the difficult things about talking about this stuff is that there's a sense in which it's nihilistic. You know, it's all doom and gloom. But actually, from my experience, that's not how people go away from this conversation. What I really, really want you to get is a sense that the dangerous situation is the one we're in now. The most exciting possibility for us is by changing. Because in the future healthcare, who is better placed than us to respond to where healthcare is going? You might say, well, is it the doctors? Well, the doctors are very powerful, the medical profession is very powerful, but they're not so interested in hands-on care. They're not so interested in putting your hands on with people. Could it be the nurses then? There's millions of nurses. Well, it could be. They've got a lot of social capital, but they're not diagnosticians. So what about people like the dentists or the psychologists or the podiatrists and chiropractors and such? Well, they generally focus on one body system, the mouth or the feet or something like that. So I don't think it'll be them either. What about the psi disciplines, the psychology, the psychotherapy, psychiatry? What about them? Well, maybe, but they don't think about the body in the way that we do. So what about the complementary therapies? Acupuncturists, chiropractors and the like? Possibly, but they also don't have the social capital and the orthodox standing, the respect of the state that we have. So what about exercise therapists? Well, maybe, but they again only deal with a certain aspect of health and they don't have the experience of comorbidity that we have. So actually, when you look at the way healthcare is changing, I don't think there's anybody better placed than us to adapt to the changing world of healthcare. But there is an enormous amount of critique coming to the professions now from outside, and I wanted to highlight, this is an amazing book. If you get a chance to read this, I would strongly recommend it. It's from Richard and Daniel Susskind, father and son. He's a senior legal writer, and Daniel is an emeritus professor at Oxford. It's a very beautifully written, clear, but still scholarly piece of work. And they say this very early on in the book. When we're talking about the professions, to pick out a few of their shortcomings, we cannot afford them. This goes back to the point about specialisation. They are often antiquated. Their expertise of the best is only enjoyed by a few. This is a massive issue. We train people for years to become really brilliant, but they can only see a handful of people a year. And their workings are not transparent. They argue very strongly that professions are in a really difficult situation. And this is something that we face as a profession, that technology now is going to radically disrupt. They say, if professionals are only able to share their experience and knowledge by advising on a face-to-face basis, then there can be few beneficiaries of the genuinely outstanding. So if you're going to specialise and become a specialist in your field, the next thing you've got to do is work out how to reach 1,000, 10,000, 100,000, 1 million people. Because that's the only way that we're going to respond to people's health need and continue to find value in what we do. We exist with this problem, and this is a problem for us as educators. We know, for instance, that there is a massive demand to come into physiotherapy from people, and that there is a massive need in the community for our services. But the universities restrict access so tightly that it's a drip feed. And so the people who are actually getting us are very few. And all of these people are not getting our care. And only occasionally does somebody bump into a real star expert who really does great work. We have to fix this. We have to find a way to break this funnel. And that means thinking about ways in which we can educate people massively to develop physical therapies. We were talking earlier on the travel up here. I'm a real advocate for physiotherapy in the future, teaching other people to help, teaching hairdressers and builders and whomever else some of our skills, so that people out there can get the help that they need. Just restricting access to physiotherapy so that we remain special is, to me, an ethical problem. The fact we are actively denying access to physical therapy because we want to remain special is a massive ethical problem for the needs of health in the community. So we have to think about that. Ethics isn't just about being nice to people and, beneficence and non-maleficence. It's also about the ethos about how we work and what physical therapies can do for people.